So the meeting recorder is now in progress. So welcome everyone to Evidence-Based Public Health, our workshop number 2, Developing an Action Plan. Thank you for joining us. In order to start today's workshop, I'd like to share a quote with everyone to kind of ponder and consider as we continue on with our presentation today. The quote is, "Even if you're on the right track, you'll get run over if you just sit there," stated by Will Rogers. Now read that one more time. "Even if you're on the right track, you'll get run over if you just sit there." So think about that for a second in regards to action planning and what that means for your work. Welcome to anyone who is new to participating on our workshops and who may have not joined us last week. And welcome back to everyone who is joining us now for a second week. My name is Yanitza Soto. I'm the Community Health Worker Program Manager with the Office of Chronic Disease at the Arizona Department of Health Services. And I'll be sharing the presentation with you today. So a brief outline of what we'll be talking about today is a recap of the timeline of our evidence-based public health training in Arizona and how this really came to be, a short summary of the modules that are included in evidence-based public health training, some group rules, the evidence-based public health framework. So hopefully the image comes to mind for anyone who participated last week. We'll be reviewing that again today, and then we'll get into developing an action plan. This timeline here is a short summary, including information on how really the thought was to bring, really how the thought was created and started to bring then the training back to our Arizona stakeholders. So back in March 2018, the Arizona Department of Health Services was invited to attend a training on behalf of NACDD, which stands for National Association of Chronic Disease Directors, and the Prevention Research Center from in St. Louis, Missouri. So Arizona Department of Health staff attended that training with the intention then to bring this resource back to our state. In October 2018, we had the Healthy People, Healthy Community IGA Fall Summit, in which county health departments participated in providing input on the idea of an upcoming webinar series, and they were surveyed on the topics of evidence-based public health and which topics of the framework they were most interested in to then receive a webinar series. Now here we are today in July 2019. We are actively engaging with our evidence-based public health webinar series. We are connecting with fellow state employees and our county stakeholders to provide this webinar series covering the 3 top choices selected by our county health departments. And we look forward now to the future of Year 5 implementation within our HPHC IGA to hopefully include information that you're learning here today into integrating your evidence-based public health practices in the work that you're doing in your communities. This outline here summarizes the modules that are included in the overall evidence-based public health curriculum. You'll notice there the calendar next to conducting a community assessment. That means these are the 3 that were selected with that icon. So the first module, conducting a community assessment, was selected. The second is quantifying the issue, followed by developing a statement of the issue, searching and summarizing scientific literature, developing and prioritizing options. The 6th one is developing an action plan, which we'll be talking about today, followed by economic evaluation. The 8th is evaluating the program or policy, which we'll talk about next week. And finally, communicating and disseminating evidence to policymakers. A quick reminder of the dates that we have been and will be meeting. So we met last week on the 16th, today on the 23rd, and our last presentation will be next Tuesday on the 30th. If you can please note, the time for next week is during the morning. So we're hoping to be able to reach everyone since we've provided these webinars at different times during the day. But noting that next week it will be in the morning, 10 a.m. to 11 a.m. Some logistics and group rules to go over would be ensuring and double checking that you are placing your speakers and phones on mute. asking questions in the chat, and especially sharing your relevant experience to the discussion or questions that might be posed to the group, and participating in our entire webinar series. So if you were on last week and you're on today, you're already halfway there. So we just have one more then next week, and then inviting any employees that you think will be interested in participating as well. So what is evidence-based public health? So this is the equation and formula that is really supportive of our approach to integrate into public health practice and the work that we do. So the process of integrating science-based interventions and community preferences to then improve the health of populations. The population health improvements are the outcomes that we track, measure, and then we hope to ultimately show improvement within our communities. Here is our favorite evidence-based public health framework. This is what we'll be reviewing, what we introduced last week, what we will be reviewing today, and then we'll be revisiting this image next week as well. You'll notice there the red title, Assessing the Community. That is what we talked about last week. Today we are on the left side in the light blue, so conducting an action plan. So this framework is a tool for public health professionals like yourself, and especially as a guide in the development of implementing and evaluating the programs and policies that we work with every day. This framework for public health professionals and partners helps to select interventions that we know and identify with being well matched in order to meet the community's needs, preferences, and capacity. So evidence-based public health and the connection or tie then with accreditation. So voluntary public health accreditation also supports evidence-based public health practices in a complementary relationship, as we see here in the image. As part of the accreditation requirements, health departments must demonstrate they are implementing evidence-based programs and interventions, as well as staying up to date on relevant research. And before we get further into evidence-based public health practice as a whole, it's definitely important to consider evidence-based decision-making and identifying with what that is. So evidence-based decision-making is the important concept to cover as the umbrella concept then that contributes to evidence-based public health practice overall. So last week, if you recall, I did provide a simple example that I'll be sharing very briefly here again today. And I would like to remind everyone that we actually participate in evidence-based decision-making on an everyday basis, whether or not we have identified that or not. It's not only in our decision-making that we are participating in with our work decisions and any type of programming that we're working with, but actually every day, maybe even our personal life. So the example I will be sharing is that I have identified and I have recognized that whenever I wear my favorite green sweater, that actually I have a really, really great day. So in the mornings when I'm deciding what I will be wearing, I come across my green sweater and I ask myself a question first of what will I wear today? And number two would be finding information and evidence. So the information I have of that green sweater in front of me and when I wear it is that I have a really great day, and that is my evidence that I am basing my decision off of so far. Number three there would be critically appraising my information and evidence. So if I consider back to the information that I have, so for the last 3 times that I've worn this sweater, I in fact have had the greatest day ever. And then number 4 would be then integrating that appraised evidence for my preference. So making sure that then my decision to wear that green sweater will be meeting the preferences of me knowing that I might have meetings that day and I like the sweater and I know that it also keeps me warm. So that contributes then to my preference for the day. And then 5 would be me evaluating that decision. So me wearing my favorite green sweater, having the best day ever, and at the end of the day, evaluating my decision and whether or not the evidence that I had to make that decision was actually appropriate. So I share this very simple example as a reminder to show you that there is a spectrum of defining evidence. We see there towards the bottom of the arrow personal experience. So that is exactly what I just shared with you, and that would be more of a subjective evidence that I just shared. It is totally based on my personal experience. I have no really data or scientific literature to support that. It is just based off of only me, nobody else, and what my preferences were at the time. You'll see there as we get higher up on the blue arrow towards objective, that is where we then see more information and support for program and policy evaluations, public health surveillance data, scientific literature, and different type of reviews, and scientific literature in journal articles. So this is a reminder and a visual to show that we should lean more towards the objective definition of evidence when we are selecting programs and interventions for our communities, and less from the subjective evidence. Here is an image also including the domains of influence for evidence-based decision-making. So not only the spectrum of evidence from subjective to objective we should consider, but also these different domains that then contribute to our overall decision-making. So there on top, we have the best available research evidence. So if we refer back to my very simple example of my green sweater, my best available research and evidence for that example was, the last 3 days prior that I had. Then we go down to the right-hand side, resources, including practitioner experience. So the only resource I had was in my personal experience. And then on the left, we have population characteristics, needs, values, and preferences. And at that moment, the population was me and my needs and my preferences, right, on what I needed for that day and what my preference was. This domain of influence is something to consider and maybe fill in the blanks here when selecting a program to implement, really asking yourself, what is that best available research? Any resources, including some experience perhaps that we might already have. Implementing a program, and then taking into consideration the population characteristics, needs, values, and preferences of your communities as well. Here is a very similar image than what we just saw before. It is including the domains for decision-making in the middle. Then you'll see there available research, resources, and population characteristics. But here we notice then the larger blue circle around includes then the environmental and organizational context that we might also need to consider when selecting programs to implement. Here is a did you know? So last week, if you recall, and if this is your first webinar, you will notice that throughout the presentation, we will have did you know slides. Although these don't contribute necessarily directly to evidence-based public health, it's still important to be informed and know these fun facts. So did you know here that sea lions can dance to a beat? So there are only 2 mammals on Earth with a proven ability to move their bodies in tune with an external beat. And those 2 are humans and sea lions. So although some humans may debate the fact that they could actually move to the sound of a beat like music, but that is a fact that sea lions then are the second mammal. And this was according to a 2013 study from the University of Santa Cruz. So we have some evidence there, right, to show that sea lions are the second mammal and humans to move to a beat. So here getting into more of developing an action plan, and so considering that after a particular intervention, programs have been identified and sound planning techniques can ensure that then programs can be implemented effectively. So many view actually that the planning is the most fundamental part and the most important administrative function of program implementation. When we recognize that our communities across Arizona have complex public health needs, and just a single program can rarely solve it all. Therefore, the goal then of action planning is to maximize the chances of efficient use of resources alongside the effective delivery of the programs. Learning objectives for today will include these 3. So identifying the steps in action planning, including working with stakeholders, understanding when and how to adapt interventions for different communities, cultures, and settings, and understand the purpose and use of logic models. So action planning versus ongoing planning. Using an accreditation lens here, we can think of your community health improvement plans, such as your CHIP, at a high level. So your CHIP is an ongoing strategic plan. However, you need a solid action plan with process measures to achieve the goals in your community health improvement plans. So if we consider action planning, the definition would be, this is for a defined program or policy with a specific time with dependent outcomes. Whereas ongoing or strategic planning is a regular function within an organization, often with long-term goals. Thinking about a strategic plan could also be thought of that a strategic plan is a destination, whereas an action plan is a collection of details about how you want to get to where you are going. We can also think of action planning as it pertains across a spectrum. So here we see an image from the Prevention Institute, where it is demonstrating that action planning does actually occur across a spectrum. So if we start at the top with number 6, that is the highest level then of that action planning could be at. So when we influence policy and legislation, that means that we are then developing at that level strategies to change laws and policies to influence outcomes for many, many people. Moving down to number 5, if we are focusing on changing organizational practices, then we would define that level as adopting regulations and shaping norms to improve the health and safety of then a smaller group of individuals. Number 4, if our focus is actually fostering coalitions and networks, then we would define that level as convening groups and individuals for broader goals and greater impact. Number 3, if we are focusing on educating providers, then that role would be informing providers who will transmit skills and knowledge to others. Number 2, if our focus is promoting community education, we know that we should be reaching groups of people with information and resources to promote health and safety. And finally, number 1, strengthening individual knowledge and skills. Then that role would be enhancing an individual's capability of preventing injury or illness and promoting safety. So referring to the level, the action planning here across the spectrum, we can see that most of our work might fall into maybe areas between 1 and 4 for the most part, but certainly within the entire spectrum as well. And also to note that from level 6 to 1, there is at number 1 more involvement at the individual level, whereas the higher you go up to number 6, it includes many more people and the masses. Sharing now some key characteristics of effective action planning for a program and policy include that they are based on evidence, assessment, and community input. They are clearly spelled out and they are making linkages across goals or objectives, any existing action strategies and activities, that there's clarity in the roles and responsibilities of all partners at the table. There's a specific timetable, so we know what we're going to do and how long it's going to take and when it will be completed. And finally, including clear mechanisms for tracking progress. So evaluation then is critical. Decision-making with partners and stakeholders. So if we consider this, why use groups for exploring intervention options and making decisions? So if everyone could just take a couple seconds to think about that. So why should we use groups for exploring intervention options and making decisions instead of just maybe exploring these options and making the decisions on our own? So some pros you may have thought of can include gaining buy-in from your community or stakeholders that may or may not have already been involved in the work that you are doing, as well as supporting cross-sector collaboration and non-traditional partnerships in public health that is very much growing and should be the foundation of our work to not only continue working with those partners or community stakeholders in which we've had the relationships already established. Those are tremendous and great, and we definitely should depend on those relationships. But it's about thinking bigger and broader, and how can you work and identify a common buy-in with maybe those partners or stakeholders and collaborators that you haven't necessarily worked with in the past. And you can both think creatively together on how to establish that relationship. And as for cons, maybe something that you have thought of is competing priorities, perhaps with other partners and stakeholder organizations, groups, or individuals who maybe they are working on the exact same area that you're working on, but yet it might be different funding sources or other types of competing priorities where we view that competing priority as a roadblock instead of viewing the competing priority as maybe a mechanism then to still work together in a more creative way. So decision-making with partners and stakeholders continued. If we think of some then advantages of working with partners and stakeholders, we know that good examples of stakeholder decision-making would be that our use of the Arizona Health Improvement Plan, for example, the AZ-HIP, we have work groups in the steering committee. So Arizona Department of Health and our stakeholders collaborate to address each of the 17 health issues outlined in the Arizona Health Improvement Plan. So both internal and external co-chairs facilitate the work groups that are dedicated to tackling each priority area. And providing guidance to the Arizona Health Improvement Plan Steering Committee helps to ensure that the plan reflects the high impact actions to move forward and to move the work forward in communities across the state. So if we look here at the slide, it includes advantages and disadvantages of working then in the partner and stakeholder setting. Some advantages include more information and knowledge is brought to the table. There's better acceptance of final decisions because those voices have been heard and present throughout the process. And more accurate decisions are generally emerging. Whereas the disadvantages may include the process takes longer because there are more individuals who are participating in the process. There may not be equal input from everyone. And there may be groupthink that may occur in making the final decision. And groupthink would include that there would not be equal opportunity from everyone since there is an ongoing topic that is being shared, and because it is a larger group, then everyone would agree upon a certain topic. Here we see steps that are included in program and policy planning. So they include step 1, establishing a goal, 2, prioritizing the intervention options, 3, establishing objectives, 4, developing action strategies, 5, assessing resource needs, and 6, developing a work plan and timetable. If we're focusing then on step 1, establishing the goal of the program, we know that the goal is a long-term outcome you are striving for. So please keep in mind, I'd like to note that these examples are solely for the teaching purposes of our topic today and may not include topic or disease-specific areas that your counties could and are possibly implementing currently in the HPHC setting. So examples could be goals that could be for the next year of your IGA or goals to include in your community health improvement plans, etc. So if we see here, if we consider reducing the burden of cardiovascular disease in Maricopa County, the next example is reducing the burden of diabetes among adults with type 2 diabetes in Yuma County, and reducing the incidence of tobacco use initiation among teens in Cochise County. So this would be our long-term outcome that we are hoping to strive for. Some helpful information on goals versus objectives and how these are different, even though we tend to hear and use these terms interchangeably, but here is the information on how these two areas are separate. So a goal is a broad statement about a long-term expectation of what should happen as a result of your program, which is the desired result. And this serves as a foundation for developing your program objectives. So criteria for goals would include that it specifies a problem or related risk factors and identifies the target population for your program. Whereas objectives is defined as statements describing the results to be achieved and the manner in which they will be achieved. And you usually need multiple objectives to address a single goal. Criteria here is that they are SMART attributes and are used to define a clearly defined objective, and we'll learn more about the SMART attributes a little bit later in the presentation. So step 2 includes prioritizing the intervention options. And this includes that it should be a systematic objective and compare options based on evidence and realities. So if we refer to the image here, we shouldn't only be having, a list of possible goals and objectives up on a wall, and we are blindfolded, throwing a dart to see wherever it lands, and that's the program or project that we'll be implementing. That's not how we should be making our decisions. Instead, they should be, as stated here, very systematic, objective, and comparing options based on then that decision-making, the decision-making spectrum of evidence and realities. Continuing with step 2, prioritizing the intervention options, we should also collaborate with partners and consider then the strength of the evidence that we are learning about, the readiness of and the fit for our community, the changeability and importance and feasibility of actually implementing that type of project or program, really considering our community and the support of local dynamics that we may or may not have, or we may need to work on building those relationships. We should consider then the length of time to see the change, our agency, mission, and vision, and whether or not that aligns with what we should all be working towards overall together. We should consider then the resources that we already have available and what then this project could support, such as staff, additional funding, or collaborators. And if maybe we could take a moment to think of any other factors that might then contribute to collaborating with partners and that we should consider. Continuing here with step 2, prioritizing intervention options. So it's really important then to refer to, here's an example of a rank-based criteria table that we can use as a tool to assess then any programs or interventions that we would like to rank and identify if in fact we should be utilizing this project or go forward with this program or intervention. So we see here the strength of evidence. So it is on a spectrum from 5 to 1. So 5 would be, for example, if you came across this program or intervention and it was provided on the Community Guide website, which we know houses many and lots of evidence-based programs already, and that's a really great tool for us to refer to. So if in fact it has been recommended on there, for example, then that program or project would receive a 5. And if we think back to our blue arrow of subjective and objective evidence, and instead if it's perhaps a personal experience intervention that we know worked for 1 or 2 people, that would most likely fall then lower on the spectrum, such as a 1. Working down would be readiness. So this would mean that some groundwork has been laid for the strategy in other states and counties across the country, for example. If the strategy has already been implemented in also some local communities, but it might still need to be scaled according to your community. And this would be what we could refer to also as low-hanging fruit, where we know we have the resources and the capacity already, and what can we really implement with everything that we have in place at that time. Working our way down then would be coordination. So this would focus on avoiding duplicating current efforts and or making sure that there is added value in some way to the existing work. And also considering how this new project would or program would accelerate or expand any existing work in a meaningful way, and how it would support any expanding and existing work in a meaningful way. And of course, then you would rate that again from 5 to 1. Working our way down to available funding is considering whether or not we can identify funding sources for implementing then these strategies or interventions. And then working our way down one more to reach. An example of this would be estimating the number of people that would be impacted by the strategy that we would be doing. So if we are thinking about interventions at a county level, maybe considering your overall county population and whether or not this intervention would reach the majority of those individuals, or if the project or intervention would only be impacting 5 people in an entire year. Really measuring then, is that really adding value then to the funding you're receiving or any existing work that you're already completing. So step 2 is prioritizing intervention options. Again, if we consider this 2x2 table, it includes on the top, so from more important to less important, and on the left-hand side, considering whether or not the intervention is more changeable and adaptable or less changeable and adaptable. In the middle, if we focus on an intervention that is more important and more changeable, then we see there in the middle, where those 2 points meet, it is the highest priority for the program focus, and that should be where our program implementation should be focused on. So moving on with in the steps in program and policy planning, step 3 now would be establishing the objectives. So ensuring that objectives are achievements and not only activities. So it's about what we are doing and not only how we are doing it. So we would like to focus then that these objectives should be SMART. So they're specific, measurable, achievable, relevant, and timely. So in specific, we'd like to focus on concrete examples and focusing again on the who or what we are expected to change, whether or not, again, it's that the tobacco usage in young adults or the cardiovascular disease in adults. Then measurable, we consider a variety of measures. So either what will we be measuring and what will we want to view at the end as being a factor of whether or not this was successful. This might include health outcomes, behavior risk factors, health service indicators, environment or policy change, as an example. For achievable, we'd like to consider that this is likely to be achieved and realistic. It may be difficult then to create objectives that at the end of the day, it's just not realistic then for our capacity at that time, whether or not it's staffing or funding availability or lack of relationships with stakeholders. What is actually achievable and realistic for you to accomplish? R would be relevant, so results oriented, meaningful, and value added, so valued results. And then T for timely, so ensuring there's a timeline within our action plan and for our objectives, and what our target dates that we are moving forward and working on continuously. More along step 3 with establishing objectives, here is another example. So an example of a SMART objective would include to reduce the percent of women in Arizona ages 35 to 55 who are overweight with a BMI greater than 25. So for the percentage existing of 37% in 2015, we'd want to move that to 32% and actually decrease that by 2025. So if we review this and we measure it on, is it specific? Is it including who, which would be the women in Arizona, and where? For measurable, it would be focusing on how much is the change we want to expect. So we know that we want to change it from 37% then to 32%. Whether or not it's achievable and realistic given the program resources and planned implementation. So I would refer then back to the measurable, whether or not it's from 37 to 30. Something that would be less realistic would be focusing on decreasing this from 37% maybe to like 10%. We know that that's very drastic and we would want to make sure that our objectives are more realistic. Relevant would be relating directly to program and activity goals, and perhaps this would be a goal that we might see within a physical activity objective, for example. And then time bounds, focusing on when the objective will be achieved. So we know here, then we can identify that it is between 2015 and 2025. But you'll notice there at the bottom of the right-hand part of the slide, the question is, it's SMART, so it's capital S-M-A-R-T, SMART, but is it SMART, quote unquote? So we'll consider that next. So what else would make objectives SMART? So there should be sound scientific evidence to support the objectives. So as we refer back and consider then our blue arrow of objective versus subjective evidence. The objectives should be appropriate for the community. The result to be achieved should be important and understood to a broad audience. Also considering how objectives should be prevention oriented. Considering also how objectives should drive action. So really considering how our objectives are SMART, so our capital S-M-A-R-T, but also small, quote unquote, SMART on including these points here. If we continue to consider then our shorter and medium term objectives, those are steps to achieving our long-term objectives. So these may include and may also be called intermediate objectives. So these generally address those knowledge, attitudes, and behavior change, as well as environmental action and or policy change. So we can consider what might be examples of intermediate objectives then for our BMI example. So we'll discuss these now. So these examples of intermediate objectives for our BMI example would include, as far as knowledge, could be stated as increasing the percentage of women aged 35 to 55 reporting that they understand the contribution of physical activity to weight loss from 47% in 2015 to 50% in 2020. So there we are measuring their knowledge and their understanding to the contribution physical activity would have. If we focus then on attitudes and intentions, how would that objective change? And the wording of that objective might perhaps be increasing the percent of women aged 35 to 55 reporting that they intend to become physically active in the next 6 months, from 12% in 2015 to 22% in 2020. So here we see if we are focusing our objectives on measuring attitudes and intentions to change, then our wording and the verbiage of our objective would include, for example, here, the women that are self-reporting as becoming physically active in the next 6 months. It's also important to consider the theory when we are establishing objectives. So this may include the explained behavior of the phenomena and may also suggest ways to affect change. This also helps to guide interventions and strategies and also guides development of the objectives. So this is suggesting what needs to be done to change behavior. So 2 examples of public health theories that could contribute to behavior change would be the stages of change model that we can refer to as a resource, and also, yes, the stages of change model. So moving along then with steps in program and policy planning would be number 4, developing action strategies. And here's a reminder of where we are as we're working down the steps of program and policy planning. So step 4, developing action strategies and change strategies. So objectives are the what, as a reminder, so that is what we are focusing on, whereas action strategies are the how, and they are what we are actually completing and doing. They are the activities that we believe will lead to achievement of our objectives, which in turn will ultimately help us attain our goal. And these are often referred to as our outputs if we are referring to, for example, a logic model. So this social ecological framework image should be familiar to any of you who participated last week, and if this is your first week joining us, this is the social ecological framework that we have been using as a resource here for the evidence-based public health workshops. As a reminder, then we work in different levels. So we'll start then on the bottom with the white circle individual level. So this includes knowledge, beliefs, and attitudes, skills, and personal traits. So the example here is health benefits such as coaching and counseling and medical nutrition therapy. Working our way up to the interpersonal level, which includes our family, our friends, our peers, our social networks and relationships, and how those interpersonal relationships then might affect our health. So this could include examples of programs such as education or physical activity clubs. Moving up to the next level, organizational, would include living and our working conditions, our institutions and their policies that we may be working in, and also regulations such as our local and state laws. So an example here includes policies such as tobacco-free work sites and nutrition guidelines for catering and vending, for example. And the last level there would be the dark green, so environmental. So this includes infrastructure and resources, and it considers also the built environment and features and safety and access. So examples would include that it's supporting such as access to health foods, walking trails, and bike racks. So if we then break down our social ecological framework at each level to then identify strategies at various levels, we see there then that at the individual level, some objectives might include addressing the knowledge, attitude, and behaviors, and some approaches could include written material for individuals, training, such as what we're doing today at the individual level, providing these workshops to everyone, counseling, or education. Moving up to the next level of interpersonal, some objectives may include some practices, social support, or social networks at the interpersonal level where others are working alongside others. And the approaches may include peer support, developing new social ties, or frontline health advisors, such as community health workers who are working then interpersonally with others in their community. Next level would be organizational. Some objectives may address then organizational programs and policies within their institutions, perhaps legislation at a statewide level or local, maybe city or county level, as well as regulations and ordinances, again, perhaps at the city level. Some approaches may include organizational change, so how this actually impacts others, networking, political action, lobbying, and advocacy. Now, at the highest level for environmental, some objectives may address our environment, obviously, and then the facilities in which we may live and work. And approaches would include the infrastructure of the environment and those facilities and any community development. So if we consider then an example of a goal would be to decrease the incidence of diabetes. If we then consider what we've learned about long-term objectives, that might include increasing the percentage of adults in Yuma County who meet physical activity guideline recommendations from 40% to 50% by 2023. If we are then tasked with identifying an intermediate objective, then that would be the next level and getting more specific. So then we would share increase the awareness of physical activity guidelines in the adult Yuma County population from 10% to 50% by 2021. And again, as a reminder, this intermediate objective may also include several sub-objectives to contribute that. And then finally, potential actions and outcomes at the end of meeting this goal could be that a media campaign, for example, was created. And again, this may have several actions for each of these objectives. So when considering evidence, we should also consider that in order to start with successful strategies that others have used could be a good point. So I referenced the community guide earlier in this presentation. This is a great resource to find any already evidence-based programs or to learn what has been implemented in other communities that may resemble your community. The Community Toolbox database of best practices from the University of Kansas, Partnerships for Prevention, SAMHSA's National Registry of Evidence-Based Programs and Practices, and we can also consider then during our search and research for what other evidence-based programs are already existing and what strategies we can learn from. Also thinking about the feasibility and practicality of our setting. So if we find a great program that has been evidence-based and meets all of our needs, but really then reflecting that on how that can be best implemented in our community specifically. And considering also the adaptability to local government. So for example, your county health department settings, your policies, cultures, and norms. So another example here would be this resource from the National Association of County and City Health Officials. So this is a community health improvement matrix. So we would have our objective up top. We have our contextual and primary then prevention levels and how that can work upstream. In the middle there, we have our secondary prevention level and then our tertiary prevention level and how then that might move across, again, the ecological framework from individual then to the right up into public policy. So one more did you know fact. So Q is actually the only letter that doesn't appear in any U.S. state name. So it's Q. If you ever are asked that question, you know the answer. Q is actually the only letter that doesn't appear in any U.S. state name. So moving along to our second objective here, understanding when and how to adapt interventions for different communities, cultures, and settings. And this could be achieved by using already existing tested interventions or programs and really asking, is it okay to adapt? So we need to first understand then the difference between fidelity versus adaptation and how that might impact the other. So reviewing over 500 studies showed that there was a positive relationship between the level of implementation, which could also be considered fidelity, and the program outcomes. However, fidelity was below 100%. Some adaptation always occurs, and there is some evidence that it actually improves outcomes. So here we'll learn different versions of adaptation, so green, yellow, and red light adaptations, and how this could provide a guidance on whether a particular adaptation may be green, yellow, which should be made cautiously, or red, that should be avoided altogether. So things that can probably be modified and adapted if you were to select a project or program an evidence-based project or program to implement, things that can be modified are names of healthcare centers or systems, pictures of people and places and quotes to better fit the needs and the look of your community. Hard to read words that affect reading level, so definitely going through and even perhaps changing out words or providing those definitions. Wording that is appropriate to your audience, ways to recruit your audience, which may have been different than the program that you've read about in the scientific literature. Also, incentives for participation, the timeline, so based on your adaptation guides. For example, if you read that this program in the scientific literature was achieved in 6 months, but you know that you have a year-long program to implement, you would adapt that timeline for your needs. And then cultural preferences based on your population. So moving along to the yellow, so the adaptations that should be made with caution. So these are things that can probably be modified, but of course we need to proceed with caution. So this includes substituting activities, adding activities to address other risk factors or behaviors that were not included in the original evidence-based publication, and changing the order of the curriculum or steps in sequence. So then moving to red, things that cannot be modified would be the health communication model or theory that was referenced in this study or literature, the health topic or behavior. So if, for example, if a program has been proven to work for asthma, it could not be modified then for heart disease. So deleting core elements or whole sections of the program to meet the needs of what you need to achieve. Reduction of the program, so reducing then the timeline or the dosage of the activities and time sessions. So for example, if the program includes 3 one-hour workshops every week, we shouldn't cut that down to 1 30-minute workshop a week if that was actually not showed in the evidence to be effective, and that was not studied and reviewed and evaluated in that way. And then lastly, putting in strategies that detract from the core elements. So then adding strategies that really don't have anything to do or were not included in the original evidence-based study and publication. So examples then of successful adaptation would be to consider then translating then the research that was done and has been done in the past years for the diabetes prevention program at a national level and how that was implemented and integrated then into rural settings in Arizona. So that includes a lifestyle coach that attends a 2-day training. It may include cooking demonstrations and common foods, and then it can be adapted to other facilities due to the lack of large public recreation facilities. So that stays very much in line with the original research that was done to prove that the diabetes prevention program curriculum was effective at a national level and how it is now being implemented across different states. Moving along then to step 5, assessing resource needs. So assessing available resources and community needs or costs. So we would consider then our available funds. Are there direct funds versus in-kind? What kind of limitations on how and when funds can be spent? Considering personnel, how many, what types, and any training needs that may be needed. Equipment and materials, what is needed, and again, any in-kind or available from participating partners. Facilities, travel, incentives, and perhaps other. So we can consider what is our public health capacity to address the need and the goal, and then really including that scope into these points here. So moving down then to our last step, step 6, actually developing our work plan and timetable. So we know that this is a critical piece for counties working on their community health improvement plans, for example. Without a defined work plan or action plan, we may not achieve our overarching goals or have a way to measure our progress. So we know that developing a work plan provides a basic plan for the construction that should also include a complete listing of the tasks that will be completed, the order of completion, so what needs to be done first, and a timeline with when that will be achieved, how long each activity will take, so this would be in time units, so for example, this would take 1 week, a couple months, or up to the years, any benchmarks that you would be measuring and performance criteria, and including especially the important information on who is responsible for each task and who should be held accountable for achieving and completing that task. So more action planning resources, which may have been mentioned definitely more than once, include the community guide, the community toolbox, the Center for Training and Research and Translation, the CDC Community Health Improvement Navigator, and also Public Health Accreditation Board. So the Public Health Accreditation, you can use the Public Health Accreditation Board standards and measures as a framework for certain items such as community health improvement plans. The Public Health Accreditation Board can also direct you to available resources from NACCHO and ASTO as well. So our last Did You Know fact includes that this tiny pocket in our jeans was actually designed to store pocket watches. So in the 19th century, when jeans were invented, this watch pocket was created to store our watches. So that's a fun fact. And our last learning objectives for this workshop is understanding the purpose and use of logic models. This will be reviewed fairly briefly. So logic models for our own information, and it is very important when we talk about community assessments, program implementation, action plan creation, that logic models are in that same conversation and thought. So logic models can come from different definitions. So they may include a simplified diagram depicting the interrelationships amongst goals, objectives, and action strategies for our program. A systems model that shows the logical relationships among the resources that are invested, the activities that take place, and the benefits or changes that are resulting. And finally, a picture that shows the sequence of events thought to bring about benefits or change over time and based on evidence and theory. Some limitations of logic models that we know is that programs can be dynamic and they're rarely following the sequential order that is demonstrated and illustrated in logic models. A logic model focuses on expected outcomes, and there are many, there may also be very many then unintended or unexpected outcomes, both positive, negative, or even neutral, that occur during the program implementation phase. A logic model does not prove that the program caused the effect. Instead, a logic model by itself does not address the questions, are we doing the right thing, or should we do this program? Those questions should have been actually addressed and answered then earlier on in the program selection and action planning creation phase. And then lastly here then, the purpose of logic models include they aid in program planning and management. They are guided steps of data collection. They define the evaluation process, including mapping to linkages on which to base any conclusions about intervention's effectiveness. They illustrate linkages that represent causal pathways. So causal pathways can be also thought of as a roadmap, which then identifies the steps necessary to achieve desired outcomes. Logic models identify primary and intermediate effects, and they aid in communication about the program. Sharing today, as I did last week, and I'll share once more next week, is a thank you to our team, our internal ADHS HPHC team, which include Desiree Green, Geraldine Haskin, Carmen Batista, and Holly Pointer. Thank you to Ross Bronson and the team at the St. Louis Prevention Research Center for providing Arizona with these tremendous resources, and thanking you for your time spent today learning more about action planning. As a reminder, our next webinar will be next Tuesday, the 30th. We'll be reviewing evaluating a program and policy, and our time will be at 10 a.m. to 11 a.m. Thank you, everyone, for joining us today. Here's my contact information. I'd be happy to follow up with you on any questions. Thank you.